Good afternoon. I welcome everyone to today's mini conference. I hand over to Kailash.
Good afternoon, friends. In fact, today we have two tasks, Sarita and Vinita. Sarita and Anita from Vinita.
Yes,
okay, talking to us on. In fact, in the kidney, a lot of us a little scared. I mean, I subject medicine one is kidney. Frankly speaking, what is the acid-base balance? I've never liked it. So I thought we should have something to know about kidney. All of us, in fact, today is going to be interesting. Dr. Sarita is going to talk to you on everything you want to know about kidney. You can ask any questions you want. She's an authority in this, so please feel free. In fact, generally, when the kidney, we think, kidney, if our lover what will you say? I'll give my heart to you, I'll give my kidney to you. But kidney is how important kidney is.
Kidney but actually, they can give only kidneys. They cannot give the heart.
No, finally, heart is solo and kidney could be another vision. But what is happening is
kidney
such an important and such a good organ also. You can donate it. Heart you cannot donate. Living heart living kidney you can give. So that way I think kidney is such an important thing. Excretory system, in fact the king is our kidney, and I think he's the only king. Excretory system skin, but kidney is the king. Okay, so we know everything about kidney today. To talk on all you want to know about kidney and all the disorders and all that. In a nutshell, we have Dr. Sarita, Managing Director of Insta Hospitals, unit of Vijay Ganga Specialty Care, a multi-specialty hospital. Focus on, in fact, it's exclusive. Of course, it's a multi-specialty hospital, but if you have anything to do with the kidney, that cast, urine, just refer to Vinita. Vinita will take care of. They'll take care of everything. Okay. In fact, we are very thankful to Vinita Hospital because last two sessions they have been good enough to give us speakers continuously. So we are thankful to you. Dr. Sarita is a graduate from Karnataka Medical College, Hubli. She further did a specialization in internal medicine from Altamont Hospital, Canton, Ohio, US, and super specialized in nephrology from the world-renowned Cleveland Clinic Foundation, Ohio. That's one of the best for Dr. Sarita worked in Jamshedpur. Why in Jamshedpur, Pune, and now in Chennai for the last 17 years as a consultant, or probably Vinod was there.
Moving around.
Correct. Working in Chennai, need preventive. In fact, I have gone to her clinic in Mylapore, Vijay Ganga Hospital. They have a very good program there for the patients. In fact, they are doing a lot of service. They have a unit called as Doctor Public Society, where they call doctors public every month, and doctor speaks to them on health prevention. In fact, they are doing service to the society. Hospital, people think we are making money. Actually, Vinita Hospital is doing service by talking to them, telling them how not to go to your doctor for diabetes, how not to go to your doctor for hypertension, like that. Okay.
And he is a starting.
I started.
Strange idea.
At Vinita, individuals are educated and encouraged to be involved in her own care. In fact, I have seen in Vinita Hospital a person who had heart kidney failure. Such a person who got treated, he comes as a counselor, isn't it? He comes as a support system. They come and talk to other patients and tell them all that. That's very good. Dr. Sarita and her team have conducted health talks in schools and many organizations, recognizing her services in healthcare. Exnora International bestowed the Seva Ratna Award in 2016. Good. Then, to bring dialysis patients into mainstream of life, enabling them to continue as breadwinners of their families and lead lives with pride. It is the aim of that is the aim of Vinita Hospital, and quality dialysis reduces the number of hospitalizations, thus saves health and wealth. Vinita is 16-month-old hospital. It's a beautiful hospital. Most of you must have come. We have had 1 or 2 meetings there come. So it's a good hospital, just 16 months old, a year and a half old, with the state-of-art facilities, expert doctors and empathetic staff, certified by NABH and has renal transplant license too. Good. You got it recently, ma'am?
Yes.
Yeah, wonderful. She is a life member of the Indian Medical Association, American Society of Nephrology, NAP. NATPU, what is that, ma'am?
NATPU, sir. NATPU. That is not the, Tamil Nadu
Oh, okay.
Society.
She speaks Hindi, Telugu, English, Kannada, Tamil. Oh, very good, very good. Married to Mr. Vinod, a nice person. Vinod is the managing director of Venita Hospital. Very nice person, very competent person. We have heard about him a lot, and has two boys. And anybody is a doctor?
Older one is a doctor in Boston, sir.
Oh, he's there, settled there. He doesn't want to come and take back.
He's just graduating from family medicine.
Oh, very good, very good. So with this introduction, let me welcome you all for this two-speaker session, following which Anita will talk on another topic, which is also equally important. Renal calculi is the only thing which general practitioners see in the clinic, so that's also equally. So over to you, ma'am, on all we want to know about kidney.
Thank you so much, sir, for a beautiful introduction. And first of all, it's an honor to be here amongst you all. I think this is the third time probably I'm doing a talk with NFI. And every single time I was received very well. The interaction was so good that it makes me come back every single time and look forward to the same this time as well. Sir had asked me about everything one needs to know about kidney, and that made me puzzled. Now what do I talk? So he gave me I was thinking, I'm talking to the doctor, so naturally I cannot go too basic, I cannot go to this thing, what exactly and how do I keep the interaction lively? So I tried. At the end of the session we'll have to tell me how it went. So what I did is basically in the form of patients that you are seeing on a day-to-day basis. So I thought, like, the way you are seeing the patients and what you should be thinking about, where you should be thinking about the kidney when you're seeing the patients. So I brought on those cases, and through which we will go through, recognize the kidney disease, estimate the stages, the functions, what the kidney does, hypertension and relation with the kidney, how hypertension and kidney are related, and how to diabetes, what are the new findings or new things that we are finding these days, and how do we protect our kidneys finally. So let's go with the case number one. We have a 75-year-old healthy farmer with no medical problems, and he fell in the bathroom and he presents to the emergency room with an ankle injury. He is alert, he is oriented, he has no fever. His blood pressure is 130 by 80, his pulse is about 65 beats per minute, 16 per minute respirations, and weight is about 55 kilos. He has clear lungs on examination, abdomen is soft, respiratory rate is normal, cardiac rate is normal. His non-tender abdomen, only left ankle is swollen, tender, and the movement is painful. So what do you want to do on these patients? I'm sure you're doing these cases every single day, right? So what would you like to do? What is the next step? X-ray. Okay, so he has a little, what do you call the strain? No fracture, but he only had a ligamental tear. So, next.
Complete blood count. Routine pump, complete blood count.
Okay.
And do your electrolytes.
Okay, sir. So, yes, we have done a blood count. Hemoglobin is 12, urea is 35, creatinine of 1.1, normal electrolytes, normal urine analysis. Anything else you would love to do? Now, what's the next step? There's something that what you are doing, so I just wanted to be more interactive, so I'm asking, don't you see diabetic? No. Well, healthy, elderly, male.
Uric acid level.
Uric acid level normal, sir.
35, creatinine 1.1, normal. They send him back home.
Ultrasonogram abdomen.
Put a plaster and send him back home.
Okay, he is complaining of pain.
Paracetamol, this give for pain.
Paracetamol.
Why paracetamol?
Huh?
Pain inflammation.
Sorry, ma'am?
Autoimmune disease.
Autoimmune disease. He doesn't have any medical problem. No medical history, no medications on a regular basis, examination is normal, is not a hypertensive. He's just come to you with this ankle pain, that too because he has fell down in the bathroom and he only has an ankle strain. So his main complaint is the pain in his ankle. It is not a fracture, only a strain.
Symptomatic relief.
Ultrasound abdomen.
Absolutely. Ultrasound of abdomen, but okay, done, normal. PSA, normal, sir.
Where is it intake?
You're thinking of it because I'm a nephrologist. No, sir. Just like what you are seeing the cases.
Systematic, you need to send back home.
Just give him a rest, man. Just give him rest. If at all the pain is very severe, give him paracetamol. That's all.
Okay, sir. He is actually a farmer and he needs to go back to work when he walks in the farm and everything, and you cannot, it's very difficult. Not like IT people that you have to sit in one place and work. For them, they need to walk. So now they are walking. He has to walk, pain is there. He has taken paracetamol, not beneficial. So, or at least that's not what was normally done in the hospitals. Right? Everybody who comes in, they are giving them normal. It is not an unusual thing. However, they are given an overall tablet. First initially injection, and then he was given a tablet because there's a swelling, the inflammatory things. People have given not abnormal at all, but just to bring it into your notice. So he was given overall.
1 ampule.
What dosage of the Overon?
Overall is an NSAID, sir. Diclofenac.
Dosage 50 milligram.
Diclofenac, sir.
50 milligram.
Diclofenac.
Diclofenac sodium.
No, 74 years.
Why give diclofenac?
No, we cannot give now.
Why cannot we give,
That's the
sir?
question mark is bringing the student.
I would like to know why exactly. Super, sir.
It
You
is,
told
it
me
is.
all basic. Huh, sir. Okay, sir. So why do you think? Huh?
Every one case from 10, they are getting
Yes,
renal
sir.
problem.
Our superstar also got the same thing, sir. Are you aware of this?
No, we had acute kidney injury.
Are you aware of this, man?
Yes, sir.
You know what tablet he was given?
I know, sir. And then he was gone to Singapore and got it done. Yeah.
He was given not naproxen, another one which is banned.
Nimucilin.
Nimucilin. He was given nimucilin, one tablet, and both the kidneys went off in one shot.
That's more dangerous than this.
Nimucilin, no? That's
Yes, sir.
it's banned.
Yes, sir. So, which is a routine thing? This is what normally people do, and this is what he has received overall, and he went home. And definitely they knew that the patient could be having gastritis, they gave Pantocid as well. Patient went home. 3 days later, he comes to the emergency room with breathing difficulty. Swelling of the feet, unable to lie down, blood pressure high, crepitations bilaterally, and ankle swelling is little bit better. So what do you think is happening here? What do you think the cause?
Acute renal failure.
Injury.
Acute renal injury.
Is normal.
Absolutely. Huh? Sorry?
Urea creatinine is normal here.
Yes, to begin with it was normal, sir. Yes. This is 3 days later.
3 days later.
So 3 days later, he comes in, and what do you think is the cause? It is an acute injury because of diclofenac. Not necessarily. Okay, wait. Not necessarily that his creatinine has gone up.
But the frequency is more.
Tendencies are more.
We are getting 10%.
And why is that? And the reason for that is this gentleman had a creatinine of 1.1, and as we know that we don't take it for a face value, when you put it into the GFR equation, it comes out to this GFR is only 45 ml per minute. So naturally, when a person's or the healthy individual, without any medical problems, without any complaints, no protein leakage or anything, his GFR is only at 45, leading a near normal life. And on him, when he is put to stress by given a medication like an NSAID, he went into failure with a volume overload status, because usually elderly people have the GFR will be less. And the point I want to drive with this is that just age is a risk factor for a kidney disease. Okay, not like having any medical problem. Only age is a risk factor. So creatinine of 1.1 in a healthy individual is also a low GFR. What actually happens with age is that there are many, even kidney ages along with the body, which is what we call as the senility of the kidney. Structurally, the many things happen. Like I don't think this is a pointer.
There must be a pointer
Okay,
on the top.
so basically, structurally certain changes happen in the kidney. The blood vessels undergo atherosclerosis, leading on to glomerulosclerosis. Tubules undergo atrophy. Interstitium goes through fibrosis, and actually the kidney shrinks a little bit with as we age. Also, the cortex thins out. ultimate result is that the GFR comes down with age. After the age of 40, every year 1 ml drops down per year. And as we are, and in some people it is even faster, in some people it is a little bit slower. And what is the determining factor of how fast the GFR drops is basically genetic. So functionally also, many other changes, because the kidney not only filters but also absorbs and secretes. So there will be a problems in every other area. So you can see them as we age, going to the bathroom very often at night because the concentrating capability of the kidneys go down. It becomes a normal. Every time getting up in the middle of the night becomes a normal for an elderly person. So fluid and electrolyte balances are abnormal. They will lead a normal life till and any stress happens, and at the time of stress they will not be able to tolerate very well and then come up with the problems. So what happened in this gentleman is the NSAIDs, they put the patient to make the patient a little prerenal, and because the prostaglandins and all go down, the renal circulation goes down, anoxia, and then sodium and water retention, all of that will put him into volume overload status, which is putting him into heart failure. So this is basically what happens after the age of 40. The decline starts happening, and it can happen at a rate that is individualized. In addition to the just age and the GFR dropping down, as we age, many other structural things are also happening, right? Like for example, in women after menopause, there will be a hormonal withdrawal which leads to the dryness of the vagina leading on down the road to the urethral stenosis. In males, prostate enlarges, and that will lead on to the obstructive features. So all of them, the lower urinary tract starts getting affected and putting the person at risk for urinary tract infections more often. Along with age comes in the other lifestyle problems like diabetes, hypertension, dyslipidemia, heart problems, everything, which are also making us give them more medications like ACE inhibitors, ARBs. All of these are again, will be adjusting or doing the hemodynamic changes at the kidney level. All of these are making our elderly fragile and susceptible to infection. The point to note is that if you have one risk factor, like hypertension or just age for that matter, if the kidney is dropping down here, but you have two risk factors, the drop at which it is happening is much more steeper. The third happens again steeper. So basically, the number of risk factors increase, the steepness with which the kidney function drops down increases, putting them at risk for protein renal failure. So, case number 2. Okay?
Madam, is it safe to give tramadol for the acute pain? We have to give some injection.
Absolutely. Tramadol is relatively okay. There is not much of a. It does, but you're giving only one dose, isn't it? Not too much. And after that, you give medications, as he was suggesting, give medications very judiciously. Ensure that you're giving, even if you're giving not more than for a couple of days, or maybe not 2 doses or more than that, sorry. Especially for elderly, looking at the creatinine values. If the same, not every gentleman who is healthy can have a 45 ml per minute GFR. Maybe his kidneys are better. In such case, they tolerate also. But in this patient, if he is not eating because of pain, so already they are at a low volume status, and already again another factor is that pain, vomiting, not eating, and then giving them one more medication. Multiple factors coming in. Have to consider that. That's all. Not every patient will go in for a heart failure with 1 dose of NSAID, but it can happen. We need to watch out for the risk.
So even if the creatinine is normal, eGFR is the most important thing to.
Yes. We should not be looking at just at the creatinine. Please look at the kidney function,
So even
which
if
is
the
the eGFR.
creatinine is 1.5, if the eGFR is normal, you don't have to worry.
Yeah, very unusual for an Indian male, because I don't think anybody has that kind of a muscle mass, because creatinine is a reflection of the muscle mass. If somebody has a very a weightlifting person, maybe in them you can have a 1.5 creatinine and then say that they have a 100% kidney function. Very, very unusual. In an Indian average male, I think 0.9 to 1. I don't think anything more than 1, we have to look at it twice.
Can you correlate the serum creatinine?
Sorry?
Ketorol and tramadol both have same risk.
Yes, all NSAIDs have SIDs. Basically, look at the GFR, then give it. Or at least tell the person that there is a possibility. So in this case, cut down your salt intake, watch out for the weight, anything problem like this, inform, don't take more than 2 doses, then you go for ultrasound or something else like that. Or go for local overall gels, they will not absorb as much. Yes, please.
So can you correlate serum creatine with the eGFR?
Serum creatine with GFR, yes, please. Usually,
There's a formula.
the ways, yes, there are 2 formulas that we use, and which is copper and gold formula, which is very, very easy without moving out from your place, without it. Yes, I didn't put it down, but I will let you know on that. Basically, it is 140 minus the age times the weight of the body in kgs, and divide that with the constant of 72, and again divide it further with the creatinine value. If that is a Cockcroft and Gall, if it is a female, you multiply the entire thing with 0.8 because it is adjusting for the muscle mass. However, in elderly, because the muscle mass is further lower, we usually use an MDRD formula, which cannot do on a, just like this on a calculator. You have to do it on the computer. So you can type out the
What is the
internet.
first one, man? It was really confusing.
Cockcroft 140 minus age.
140 minus age
Multiply that with the weight in kilograms.
into
Weight in kilograms.
weight in kgs.
Divide that by 72, a constant number.
72.
And then whatever comes out, divide that by the creatinine in milligrams per dl.
The final, I think, finally you divide by
The creatinine in milligrams per dl.
You can each time when you go into the sophistication of doing this, you have a ready-made app from National Kidney Foundation.
what is the app?
So that app,
You type up
We are
the
not
just type up
we are
the
not
name.
good at mathematics, so it's better.
no, you just got to have the app. It is from National Kidney Foundation. You go
What
to
is the name of
Google.
that?
You go to Google and NKF, National Kidney Foundation.
Okay, much easier.
Or
So
just
you
go-
can just download.
You can also say the GFR calculation on the net, which will also take
Also
you to the
tell you
same
the
thing.
same.
There are 2 formulas, MDRD and Cockcroft and Gall.
NKT.
NKF.
NKF.
GFR.
Kidney Foundation.
GFR calculations also there.
GFR calculation or NKF or whatever.
Because elderly you have lesser muscle mass, and to get a better this thing you go to use the MDRD formula.
So just creatinine is enough to assess it.
No, always look at the GFR. Yes, please.
Serum creatine level is 1.4, where eGFR is 16. How will you correlate?
Serum creatinine is 1.4.
1.4 for so many years.
Yes, sir.
And the recent eGFR calculation is 16 in various labs.
16 or 60?
16, 1.6.
1.6.
And the output is normal.
What is the weight of the
Output
patient?
has nothing to
The
do.
patient is 60 kg.
Okay, sir. You can look at 140 minus age is how much, sir?
Age around 54.
Age is 54. So, ma'am, can you start doing that? 140 minus 54 will be
Go to the app. Go to the app.
86 times 54.
Yes.
Okay, and divide by 72, 154,
One minute,
so
1 minute.
65 divided by 1.5. So around 35.
Ultrasonogram shows medical stage
Renal
1
disease.
mitral renal disease.
Yes, sir.
Okay, there are at least
Output
5
is
formulas which you can download and use it. So whatever he says,
1.5 comes around 35 ml per minute GFR.
1.5. What is the weight you told me?
55.
Okay, what is the age of the patient?
50, around 50 to 55.
40 to 50.
And
It's about 35, sir. Which puts in patient into a stage 3B kidney function, which is very
Not
less.
16, not 16, as you said.
Is GFR is
1.6.
No.
That's why I'm worrying. I am bearing my head.
How are you calculating? This is the way to calculate it.
It's a VIP.
How much did you get? 35?
I just got 36 ml per minute. Okay.
That's what I told
So
you.
normally
34.
what happens, nobody in Indian scenario can get a GFR of about 120, 180 and all that. We regularly do for our transplant patients. Transplant patients are all healthy donors. Okay. So we do 2 things for a healthy donors. One is we do an estimation of EGFR, that is EGFR. The other one, what we do is the actual glomerular filtration rate with the radionuclide scan.
Nuclear scan.
With the nuclear scan, that is called measured GFR.
Okay.
And then we see an average of measured GFR and EGFR. When we do that even on healthy adults who are otherwise normal, who are class 1 patients who are to be donating the kidney, nobody's GFR comes to around 110, 120. These are all Western calculations which they have said. You can see a similar paper from Vellore which says in all healthy patients you can get approximately 80 ml per minute for an Indian average. So how do they calculate? They see the height, they see the weight, and then they see the kidney size, and then they see the volume of the kidney. So with all that, they plotted a graph. At CMC Vellore, there is a paper. If you are interested, you can go ahead and see. So these are all only practical guidelines. What happens to an individual patient is your own assessment to see how much or how far you can go. So we don't reject them just because their measured GFR is 80. We do take, many of us, and not only that, we take diseased donors also. So what happens, so this is only, we take marginal donors because we are in a place where there is a donor pool is very, very poor. So these calculations go approximately, provided somebody has no proteinuria, no hypertension, they are classified as class 1. Even then, you can take a diseased donor with a marginal hypertension of 1 antihypertensive, but not proteinuria. So all these calculations are only practical guidelines.
What advice I have to give to this patient?
So that patients are first and foremost, the way you have done it. Basically, creatinine is like a thermometer, telling you, hey, something is high, look into it. Then you get an estimate. The estimate is by calculation by using this formula, which is coming to be about 35%, 35 ml per minute. Now, if you are in doubt, go ahead and do a 24-hour urine, or which will give you a better, that will measure your kidney function. Okay, so it's like if you're buying a car, first you get an estimate and then you get the actual price.
Normal output.
Yes, sir. Normal output is not exactly, sir. Kidney, this is the major. If the doctor also should be understanding that if there are conditions in which you have 2 liters of urine output and yet you are not able to clear the waste products. Okay, so such is also a kidney failure. So kidney has many functions. If one of the function is failing, that is also a kidney problem, sir. So just urine output passing is not the only feature of kidney. So that's exactly what the second and third things will be showing to you, sir. We'll come to that. So the second, first and foremost is to waste product elimination and the GFR, which is a marker or an indication of a kidney problem. That we understood. The next problem is this patient, a 53-year-old obese female, developed stomach pain and was diagnosed with a gallbladder stone. These are all real cases, trust me. And surgery was advised. So she's afraid of the surgery and she went in for an alternative medicine. And then she was started feeling fine. However, after a month, she developed leg swelling that increased gradually. Okay, so also she noted a foamy urine. Her daughters were started to yell at her, you are not flushing the toilet properly. And fearing the kidney disease, because she heard about leg swelling and kidney thing, she came to check out if her kidneys were alright. Then her blood pressure is 140 by 80. She has a heart rate of about 83 beats per minute, 20 per minute respirations, 88 kilos weight, BMI of 40, clear lungs, respiratory rate is normal, soft abdomen. At this point she is not tender, there is no abdominal pain. She still has edema to her knees. Now what do you think? Yeah, a fat Indian female having about the age of 50, having a gallbladder stone is not unusual. At this time she is not in pain. However, she used alternative medicine for the same and now comes in with the now we do the creatinine. So this is a history. So you are asking for the creatinine. Yes, I have got the creatinine. Creatinine is 0.9. Okay, hemoglobin is 11. WBC count is 10. Normal electrolytes. Only thing is, she gave you a history of foamy urine and that confirms that her urine albumin is 4+. So now what do you think about this?
What is the EGFR?
Liver size.
Liver size, normal, sir. We didn't do a liver size to be honest, but I will tell you no normal.
Patient is obese,
Yes, sir.
likely to be fatty liver.
Fatty liver, but fatty liver will not give you, I mean, at this point, she's not, that is not going to be our concern.
The LFT.
LFT is normal, sir.
Alternative medicine would have caused this problem.
Absolutely. What problem are we talking about?
Nephrotic?
Absolutely. So basically what we are seeing here is a protein leakage, which is a abnormality. So kidney's function is not only to put out the waste products and the extra fluid like you mentioned, but also to retain what is required to the body in the body itself and not let that out. So the minute you see a protein leakage, that is a sign of a kidney problem. So now we do a jargon of tests to understand how much is she leaking and what is the reason for that. So we have done all the testing, the serology, immunological profile, C3, C4, ANCA, double-stranded DNA, APLAR, the membrane, everything we have done and all of them have come back negative. So then what do? We don't have an answer with the serology and clinical. Therefore, suspecting the alternative, again we have done a kidney biopsy which proved that she has a membranous nephropathy. And again, I didn't write it here, but APLAR negative, which is meaning primary membranous is not there, but she has a NEL positive antibody, suggesting that most probably the alternative medicine which has caused her to get the nephrotic syndrome. Okay, and nephrotic syndrome is clinical picture, membranous is a histological picture, so going and correlated, and we stop the medication. However, what I want to reiterate here is that kidney's function is to retain what is important to the body. So protein leak is abnormal and it is a sign of a kidney damage. Okay, so again here people may leak up to, they leak albumin, but sometimes we measure protein. So don't need to get confused between the two. If you are looking at the albumin, up to 30 milligrams of albumin leaking is normal. It can happen even after a strenuous workout or even when the person is having fever or something like that. We always check the protein twice, not just once, unless it is like huge amount. If it is just 1 plus it's only 30 or something like that, we repeat it again to confirm that it's a persistent proteinuria. That is a problem, and then we quantify it. To measure again, we can use either 24-hour urine for an absolute number, or which is because tedious, we also it is difficult to measure. So for the patient, not for the lab, therefore we go for the spot urine at any point of time, where we look at the protein to creatinine ratio, which will give us a fairly good idea of estimate again of how much protein the person is leaking in a day. So based on that, we say non-nephrotic range, which is less than 3 grams and more than 3 grams is the nephrotic range. So this lady is leaking out about 8 grams of protein, which is an abnormal thing. Okay. So this is again, proteinuria is an early sign. It is a warning that a patient gives us to tell us that he is at risk, but not only the kidney, but also the other organ damage. So it's a very good marker that we have to look in every single patient. And important is not just we look at it, but we also can do something to protect by giving certain medications which can protect not only the kidney but also the other organs. So by now, the staging of the kidney is based on only 2 things. That is one, the GFR, which you can use a methodology which we talked about, and the second is an estimation of the protein leakage. As you can understand, as the higher the protein leakage, the faster the decline of the kidney function. Therefore, it plays a very vital and major role. And our aim and goal has always been to reduce the protein leakage to minimum as possible, so that steepness with which the kidney function drops is controlled.
Protein leakage is measured as 1 plus 2 plus 3 plus urine.
That is an estimate, sir. And then you measure it, quantify it. And when you quantify it, you can say what is how many grams per day you get. That is a protein creatinine ratio.
24-hour urine.
24-hour urine is an actual measurement. Estimate is a protein creatinine ratio. So there are 3 levels. Dipstick, if it is negative, it means that you may still have the protein leakage, but it's less than 300 milligrams. So,
do you have any statistics on how many patients go for a kidney problem after this alternative medicine?
Yeah. I mean, we don't have the statistics, but we know very clearly that many people today's day, especially after the homeo and Ayurveda being promoted very well these days, lot of people with the Siddha medication and homeo medications are coming to us. And in the last 2 years, that is after the COVID, ever since we started the hospital, I had 3 patients.
And not only that, the first
report
report about membranous nephropathy with null positive from India is done with a mercury level. Okay, the mercury level in the water content, the mercury level in which the drug was taken, and null positive is very sure to say that these heavy metals are being used in alternative form of therapy. So we exactly need to tell them, kindly get whatever you are taking, and I think IDPL can help us to analyze. Now Lister Lab is analyzing heavy metals also. So if you get a proper history, you can always send it and tell them to estimate, they do. And then this is being regularly sent to ICMR.
Allopathy medicine never produce membranous nephropathy.
So there are certain allopathy
There are
medications
allopathic
also.
medicines also which can produce membranous.
However, we have a good data that we know. I think the only plus point in allopathy is that we know this medicine causes this problem. This medicine does not cause this problem. So we can clearly say that. We don't promise that there is no side effect of any medicine. That's the only advantage. However, once we know the side effect of that medicine, we follow them up. The earlier we see, we stop it. However, with Siddha medications, they actually promise them that nothing will happen. These are very homely medications, no side effects. That's when the problem happens. So I think...
not only that, patient mix up many things. And it becomes a big awareness. Then finally you cannot blame anyone. So that's happening in a very big level in Indian scenario. So there is nobody to question, okay, you go to Siddha and continue with them. But patients turn back this side. And then patients are not happy, they go back that side. That is normal. That's normal human tendency. Come on.
What are the metals you have detected so far?
Sorry?
From homeopathic medicine.
We have detected mercury
Okay.
in good amounts, and then we have detected also some arsenic in very small amounts, but toxic to the kidney level. And then we have estimated gold salts.
Oh.
You know, I was when I was doing MD, the ex-chief minister was admitted at Apollo Hospital, and we still have the slide with us. He underwent a kidney biopsy, and we can see the golden crystals and needles in his biopsy, and that is regularly kept in DNB exam. As president, without the name, right?
It's true that it is increasing. So it is very, very important that we tell them that, hey, watch out what you are taking. At least ask your doctors, is there a possibility or not. Invariably, they will be told that nothing like that. But there are 3 people that in the last 1.5 years that I myself have actually dialyzed them. And after stopping the medication, maybe after 2 months or so, we were able to stop the medication and the kidney function has returned almost to like 60%. Okay, so now coming to the knowing how to label or in whom you are looking at the kidney problem.
But
now,
madam, you are talking only about creatinine. Urea is not an important parameter, right?
Not a very, it goes tags along with your creatinine. Because the creatinine is actually a measurement of the muscle mass which is much more steady. Whereas urea depends on how much of a protein you are taking, it depends on how much of a water you are taking, it depends on how many medications are causing a decreased blood flow to your kidney, so many things like that.
So
therefore, it is not
EGFR urea is not taken into account.
Usually no, sir. No. It is only added on. Okay, urea is high, creatinine is high, urea also high, okay, they both are correlated together. That's how it goes.
So there can be conditions that urea is normal, creatinine is high.
Definitely.
Yeah.
A patient with liver disease, urea is not produced in the kidney. Urea is produced only in the liver. Only ammonia is converted into urea in the liver. So when somebody has a liver disease, you don't get the urea.
That means if I want to do a kidney test, I should do a creatinine rather than the sick.
Absolutely.
But
usually
so normally we do urea creatinine
together.
Urea creatinine, now the creatinine is a routine test now.
Yes. Thank you, sir. I really am happy to hear that. That's exactly the point. Great. So let's go to the third case. I can see you're already aware and into this thing. 67-year-old male with hypertension, dyslipidemia is seen in the OP for the routine follow-ups. Okay, and he doesn't have any complaints as such. His granddaughter says he is not active these days and is slow in his movements, and at times in the night he thinks he's confused and he is urinating elsewhere. Okay, and there's urine on the floor. So this is a complaint with which the patient was brought. The patient says happy, smiling, lethargic, and says, I'm fine, I have no problem. Okay, what do you think? His blood pressure is 140 by 80. He doesn't have any neurological damage. Examination is absolutely normal. The medications the patient has been on, I know this is your next question. So he's on amlodipine, Metaxel, clothalidone, atorvastatin once in a day. What do you think is happening, or what do you suspect?
His prostate is okay?
His prostate is okay.
Clothalidone is the morning only.
Correct.
Absolutely. Kidney not only puts out the waste products and retains what is important to the body, that is protein, but it also maintains a healthy environment of the body by checking out the electrolytes. So his electrolytes are sodium of 125, potassium of 3.3, bicarbonate 25, urea 35, and a creatinine of 1 milligram per dl. So what do you think is the reason now?
Now, what are the drugs he is taking?
He is taking amlodipine, beta blocker, clothalidone, atorvastatin.
What is it? I don't see so.
Clothalidone and atorvastatin.
Atorvastatin. How much milligram?
10 milligrams once a day.
How many years?
Maybe 10-15 years.
Maybe dyslipidemia and atorvastatin causing.
What can it cause?
But why is it urine on the floor for the atorvastatin?
No, maybe sodium.
Sodium is
Sodium.
Sodium is much more
Anemia.
He said you are.
Atorvastatin doesn't do anything that the complaints is coming here with. Atorvastatin doesn't cause weakness. Atorvastatin doesn't cause the confusion. It doesn't cause a person to be slow. At the most it can cause is a person can have difficulty in getting up from a chair because of the proximal muscle weakness. That's it. Other than that, it doesn't cause anything else. And
He is taking ARB with the clothalidone.
No, sir. He is only on amlodipine, metoprolol, clothalidone. So the sodium, you think, can explain what he is having?
Lethargy.
Absolutely. The lethargy with which he is, the confusion, slow movements, all of this can be because of hyponatremia. And be aware, very common. And very often that we are seeing. Absolutely. What do you think it can be because of?
Low sodium intake.
Absolutely. This is again multifactorial. This is what I want to drive in. Although, yes, definitely we want to say that chlorothalidone is a tip-off. Chlorothalidone is causing low sodium in this patient, no doubt. However, elderly patients are much more. If you give the same chlorothalidone to a 20-year-old who is eating happily, healthy, and is having hypertension, nothing may not be happening as much. However, in an elderly patient, when we give chlorothalidone or a HCTZ, the hydrochlorothiazide group of medications, they are particularly prone to go in for hyponatremia. Therefore, whenever, all the papers say a diuretic is a must. Yes, it is a must. But choose a diuretic cautiously, and whenever you give the diuretic, please check the electrolytes a week later to ensure that the diuretic is working efficiently without the side effects. So, chlorothalidone is known for this, and all, especially in elderly, because they already have a low volume status and their sodium intake is low. Most of them are told don't take much, and they're very sincere, so they don't take as much of a salt. And not only that, as such, protein intake, urea intake is much lower. Therefore, they're already predisposed to have a low sodium. On top, this medication. Now, these people, he did not feel anything because it didn't come on him abruptly. It's been there for quite some time. Therefore, it's a chronic hyponatremia in this gentleman, and which is why he is having fatigue, nausea, vomiting, dizziness, gait disturbances. all of this. So very serious, when it is lower only you can get the seizures, coma, brain and all.
So this case, what is the dosage of chlorthalidone?
He was on 12.5, sir, which is a recommended dose, yeah.
Once daily.
Once daily. So he's on an appropriate dose, but not the right person, and we need to follow them up properly, that's all. Being aware is all that is needed for us to have. So kidneys play a major role in the salt and water imbalance. So not only the waste product putting out, retaining what is needed to the body, but it also takes a very sensible part, maintains the balance of salt and water. And you know, low sodium meaning brain swelling. High sodium meaning drying of the brain. So both are affecting the CNS. So very got to be cautious about this. And how does the kidney or this thing manage the water and salt balance is by checking the hypothalamus, which is checking on the osmolarity. So either if the osmolarity, if you take like 10 liters one day, for whatever reason, 10 liters you take, kidney can actually put out everything. Okay. However, if you take 20 liters, it may not be able to. Provided you are able to take good amount of fluids and all. And this is all managed because of the antidiuretic hormone suppression, or by increasing the thirst or decreasing in the thirst. There is two ways through which the sodium levels and the water balance is maintained in the body. Both of them act on the distal nephron tubule of the kidney, and that is how it is maintained. So thiazides are more common. They because the distal tubule is where they act, and that is where the antidiuretic hormone prostaglandins all work. And elderly are more common, more affected because of their poor intake and low body mass also.
What is the blood pressure of the previous case?
140, sir.
140?
140 by 80.
How much you have to maintain?
Elderly, sir. Absolutely right. I mean, irrespective of the age, it should be lower than 140 by 80. If they can tolerate it. The only difference what I see is if it's an elderly, I bring it down slowly. I don't aim for it to come down from 170 to 140 directly. We bring it down slowly. Bring it as, because they're used to it being high for a longer period of time, bring it slowly as they tolerate. If they're not tolerating, then we back off.
How many drugs he received?
How many drugs? 3 drugs only, sir.
Why?
Amlodipine, because with that his BPs are in control.
He's getting diuretics and calcium channel block.
And the beta blocker.
And the beta blocker.
Beta blocker.
There has no role for hypertension.
See, now it's 140, but it would have been high.
Beta blocker won't control the blood pressure.
So he's a heart patient also for being such a long time.
If he has CAD, they'll
Only
give
for
beta blocker.
arrhythmias.
Yeah.
The diuretic induced tubular malabsorption.
Sorry, again.
Diuretic induced tubular malabsorption.
Of course, the work of the diuretic is only to reduce absorption of the sodium along with which the water gets out. That is how it causes diuresis. So the work of that is that along with the sodium, we also lose the potassium, we lose the fluid.
Yeah.
So that's the work of it, and that is how it controls the blood pressure.
Treatment is only high sodium intake.
Absolutely, ma'am. Especially most of the elderly, whenever they have a low sodium, there are two problems here. If they are having a low sodium, either because they're not eating very well and their nutrition is very low, or they're having too less of a salt. So in both of them, before restricting just the water, we actually ask them to take more intake and normal salt diet. That is the way to treat the hyponatremia in elderly. So now that in the three functions of the kidney, the next come to the fourth one. 21-year-old female graduated and had a pre-employment checkup. Her blood pressure and examination is 180 by 110. She assumed it to be because of stress. A month later had a seizures and was brought down to the emergency room with a 200 by 140 blood pressure. She was drowsy with a mild swelling in the feet and has papilledema.
Height to weight.
Height and weight. Sorry sir, I don't have it. However, it is a normal fit female.
Hemoglobin 8 grams.
Hemoglobin 8 grams, fasting blood sugar is about 80, urine protein is about 2 plus, kidneys are about 7.5 centimeters in size, and urea is 100, creatinine is 8. Adrenal gland is normal.
Hypertensive.
Contracted kidney, yes sir.
Hypertensive nephropathy.
Absolutely sir. So this is whether it is a hypertensive nephropathy or a kidney causing hypertension. This is where we need to look into. Hypertension is one of the signs of a kidney disease. Okay, so always any patient coming to you with a hypertension, please look at their kidneys to see if is that caused because of the kidneys. Okay, that's the reason for this case to be posted to you. So we call this as a malignant hypertension, and this malignant hypertension is because of the kidney, as the kidney is shrunken and the GFR is low with 8, unable to put out the fluid, with the fluid retention, and that is the reason she is having hypertension. So it is a secondary hypertension because of the kidney disease.
What are the other hormones?
Sir, in this patient there is no real need to do hormones because it's an extensive workup. When you have already, you're absolutely right. If a person comes to you with a creatinine of 1.1 or 1.2, yes, I would do all the workup. Especially a young girl like this coming in with a creatinine of 1.2 and maybe 1 or 2 plus, that can be because of hypertension, or kidney can cause hypertension either. At that point, you rule out the other causes like pheochromocytoma or anything, again depending on the history. Every patient who has a renal Dopplers are always done, and if the renal Doppler, in this patient renal Dopplers are normal, but she has a shrunken kidneys. So this is something called the chronic glomerular nephritis. Yes, please. She didn't have any hem. She didn't know anything. All she did was, like I said, and this is not an unusual case, sir. We see this one every week. Every week almost I have been seeing one patient going in for absolute youngsters, even medical representatives sitting outside waiting for some time, absolutely have no medical problem. But we are doing a camp and we check them out, their creatinines and their blood pressures are like this. So, completely asymptomatic.
No, renal Doppler.
Hypertension is the reason. Yes, sir.
Renal Doppler.
Renal Doppler is normal.
No stenosis.
No stenosis. Okay. And also when you look at the electrolytes itself, they'll give you some idea about the hyperaldosteronism, like adrenal function. So this patient is not a diabetic, sugars are normal, not obese.
What's the reason for contracted kidney?
She probably has something which is a primary kidney problem, because of which she is having hypertension. Primary kidney problem in persons who are losing so much of a protein, we think it is because of a glomerulonephritis. So glomerular injury, chronic glomerular injury, which happens slowly over a period of time and the patient does not notice. This lady might be having this frothy urine, ignored completely, hypertension, ignored completely. She knew about the hypertension, thought it is only because of stress, ignored, and now ends up with a malignant hypertension, causing a further damage, meaning kidney damage, primary kidney damage, causing blood pressure, but blood pressure not being taken care of, further worsening and speeding up the kidney damage. So it's a vicious cycle that is happening, ending up into the aggressive kidney failure. So this could be broken down. So secondary hypertension, and usually kidney patients have a resistant hypertension. What do I mean by that is that these people normally require more than 2 to 3 medications, and one of them is usually a diuretic. And in spite of that, with the 3 medications, when it is not controlled is when we call it as a resistant hypertension. Any patient with resistant hypertension, please look for the kidney injury.
What machine do you use for hypertension measuring? The electronic or analog?
Absolutely good question, sir, which is a practical question. Many days, see, the initial days we always used to say measure the blood pressure. There is a methodology to measure the blood pressure. Neither we do have time nor we do have a proper technique who is doing it, listening manually. Therefore, I don't mind switching on to the automatic ones. But even in the automatic ones, like Omron and all is designed only for common people who do not have problems basically. But an elderly, obese, or somebody who is already a hypertensive, I would switch on to a brand which I am using on a day-to-day basis. I don't want to take the name, however, I have to tell, which is Sarita, which takes the blood pressure measurement adequately, and it is a validated machine. And I use it on a routine basis, and I'm happy with the medicine. Yes, sir. I know it is any common people also can use it, like Omron. However, it is a validated machine. It is an oscillometric methodology with which it measures the blood pressure, and it is equivalent to what we measure as physicians. So therefore, I recommend them, and I would say every person please go get it, and I do have that in my pharmacy as well. Because I believe
Is it expensive?
No, sir, it is not very expensive. Gives a nominal.
Graph of the ambulatory blood pressure monitoring.
Yes, sir. Why I want to talk about the ambulatory blood pressure monitoring is also because many times in the initial stages, kidney patients especially, in the early stages, you have a nocturnal BP, sir. Majority of the time, in the morning when they are coming to us, their blood pressures are normal. However, at night time, their blood pressures might be much higher. So, it is an early kidney disease also, they have high BPs at night, and it is only picked up on the 24-hour BP monitoring. So, anytime you have a suspicion of the BP is being under control or not, I would go ahead for the 24-hour BP monitoring, and it gives us very good results.
On the reading of the morning surge.
Morning surge is anytime patient has...
Stage.
Sorry? Sir. Yeah, he does. Yeah, that is also bad. So, early morning rise is also very bad. So, all of them are more common in kidney patients. So, any kidney blood pressure not in control, or I want to know and ensure that it is in control, I do a 24-hour BP monitoring and it gives me adequate results. Next is the crossing time ratio.
Now, what are the drugs you are using for that case?
On this patient, sir, but basically immediately we want to put them on the nitroglycerin, lower the blood pressure, labetalol, lower the blood pressure, and then switch them on to the oral tablets.
Any specific drugs given at the night?
At night?
Yes.
Later on, sir, yes. Nowadays we give them morning and evening for a better coverage because no medicine is 24-hour medication. So we give them twice in a day, strict doses are given. So hypertension, as you know, is also the feature of kidney disease. Now coming to another next case, 65-year-old female with hypertension, diabetes, dyslipidemia, bypass surgery, and CRF complaints with, her main complaints today's date. She has everything. Now she comes to us with the body aches, muscle aches, back pain. What do you think could be happening? Her examination is normal. Blood pressure is only 140/80. Doesn't have any swelling. And investigations as we do, it's about 10 hemoglobin, 75 and 3 creatinine, sodium 135, potassium 3.6, bicarbonate 18, calcium of 7.6, phosphorus of 6, albumin of 4, vitamin D 25, IPTH of 100, alkaline phosphorus of 200. What do you think?
Low calcium.
Sorry, calcium is about 7.6. Yes, calcium is low. Vitamin D is 25. Not that low, but little bit, that's all.
Now, we used to get only 25 for vitamin D.
Sir.
For all.
Sir. So, what explains her main complaints now? The body aches, muscle aches, back pain, maybe a fractures. What is the reason in this? And she's a kidney patient. So, absolutely right, you are looking at the bone. Only the bone, kidney maintains the bone health as well. And when that doesn't happen is when we have osteoporosis. That is the reason most of the kidney patients or anybody having complaints of non-specific vague or even non-kidney patients coming with vague complaints always look at their bones. So, this patient had a DEXA scan done, showed osteoporosis. So, kidney patients are a little bit more complicated. Not just osteoporosis is existing anyway, but on top of that we also have bone mineral density problems. So bone strength is basically determined by 4 things. The density architecture, which is what we check on the DEXA scan. In addition to that, mineralization and the bone turnover are altered in the kidney patients, and these two are based upon the calcium, vitamin D deficiency, which will cause a low calcium and a high phosphorus, and then PTH is stimulated to maintain more of calcium, which also increases the phosphorus, and that is how we have bone weakening, sometimes adynamic and all. So these patients, every kidney patient, we need to have check for osteoporosis, treat them for that. After correcting the mineralization issues, then all their non-specific problems will be better. We will reduce their fracture risk as well. So, kidney plays a major role in bone strength. Last case, 36-year-old female with a type 1 diabetes for 15 years, in good control, has only 1+ proteinuria and a normal creatinine. But she accompanies with her mother, who is 65-year-old with the type 2 diabetes for 6 years, creatinine of 3 milligrams and proteinuria of 3+.
Who's the patient here?
Both of them. Both of them. Maybe the first one is not my patient, but yeah, she accompanies her mother. The striking feature Here is that. 15 years of diabetes type 1 and doesn't have much of a kidney injury. What did we learn? Usually, there's not much of a studies in the past or for a very long on type 2 diabetes which related to the kidney. All we said is type 1 diabetes, 10 years down the road, you will develop an end organ damage, and so microproteinuria goes on to macroproteinuria, and then you have a GFR drop, and then you have a kidney injury. So this is how it goes, and it's a one-way street, there's no reverse. Right? However, we see a huge difference between a type 1 and type 2 now. To understand that better, many differences have come up. I think one of the studies have showed that compared to type 1 and type 2 patients 10 years down the road, okay, we see that type 2 patients are much more commonly developing complications, okay, when compared to the type 1. So the ophthalmic problems, the chronic kidney disease problems, cardiac problems, stroke, amputations. So in toto, the microvascular and the macrovascular problems are much higher and much more in type 2 diabetes when compared to the type 1 diabetes. Okay, the only difference that we can see is that acute type 1 diabetics are more prone for acute kidney injury when there being any infection or the drugs or things like that. But otherwise, type 2 seems to be much more problematic than before. So, a lot more learnings are happening now on diabetic kidney disease. As you can see, the nomenclature has been changing. Initially, we were talking about diabetic nephropathy, then we talked about diabetic kidney disease, and now we are talking about diabetes in chronic kidney disease. And the reason being, we are now able to distinguish that any patient who has a diabetes and a kidney problem, we are putting them into 3 categories. That is, clinically we are seeing either albuminuria or we have a low GFR. When you look at them on a biopsy, you are seeing that glomerular lesions or you are seeing tubular lesions. Not necessarily, both have to be there. Okay, either or. Now, above and beyond all of this, even recently I have a patient who actually is a 35-year-old patient, infertility, was coming in with the swelling of the legs when she went in for the infertility treatment, and turned out to be that she is having every parameter. HbA1c is about 6.9, new onset. Did not have anything else before. She is a software employee, so every year checkups were being done. Yet her creatinine was about 1.5 and a protein leakage of 2+. We did not know what was happening. All the workup was negative. Did a biopsy, turned out to be a diabetic nephropathy. And her doctor would wow, saying that with her HbA1c of so much, how can you say that she has a diabetic nephropathy? I said, sir, I only have a biopsy report, because that's ultimate. So what is that telling you is that there's much more to this diabetes, wherein now we are coming up with the molecular diagnostic things which are actually telling us not necessarily you have to have all these features, neither clinically or morphologically, but you can just have the molecular features which can also give you the diabetic changes. So a lot more is coming up. Stay tuned, I guess. As of now, nothing much. So basically, take home points. Kidney also ages despite no medical problems. It filters the waste and maintains a healthy environment of the body. GFR is a measure of the kidney function, normally 100 to 120 in Indian people. And after the age of 40, GFR drops normally at a rate of 1 ml per minute. In some, it may drop steeper than normal, and that is because of the genetic variations. Use either a Cockcroft or Cord formula or an MDRD formula on the laptop for the bedside to estimate the GFR. Please treat all geriatric patients as if they have a kidney disease and be very cautious, especially when we are using nephrotoxic medications, even if it is 1 dose. That is what we learned from the case 1. Case 2 indication is that protein leak is abnormal and is an early sign of a kidney disease, will delay the kidney progression and protects the other organs if we are able to address the protein leakage. Third case is mainly aimed at kidney maintains electrolyte balance, and therefore electrolyte abnormalities suggest a kidney involvement, and we have to be cautious with the medications that we are using. 4. Every hypertension patient should be checked for kidney function, and please use the 24-hour BP monitoring to protect the kidneys better. Case 5. tells us that every kidney patient and elderly are at risk of the bone disease. Do the screening and prevent them from having fractures. Case 6, I wanted to reiterate that diabetes is now becoming reversible, so is a kidney disease. Even that seems to be getting better, provided we catch it early and treat them early. So, reality check very quickly. We are able to see that when we know the kidney problems, but why is it important? Well, I think it is important because 10 to 15% of general population seem to be having a kidney disease that is undetected. And as far as the Indian Sikh study goes, the prevalence is about 17%, and 6% of them are diagnosed at a later stages. And females seem to be at a much higher risk, and elderly, so as elderly. After the age of 75, 1 out of 10 individuals seem to be having a kidney disease. So risk factors are very common in your, as you can see, and the other risk factors are these: glomerulonephritis. Only I think these are the ones that we see often. The first one, diabetes, hypertension, is something that you normally see. And so what can be done? Yes, please understand it is preventable and it is treatable. So what can we do? Control the risk factors. There's something called the primary prevention, secondary prevention. Basically, try to prevent the problem. Once it starts, control it so it doesn't end up into an organ damage. And even when an organ damage happens, ensure it doesn't go into a failure. So at every stage, a prevention can be done. All it requires is for us to be a little bit more proactive, involve the patients in their own care. So how do we do this? By screening the individuals, health checkups every day, above the age of 50, who smoke, who have diabetes, hypertension, family history, or somebody who's taking medications on a regular basis, or coming up with urinary infections and kidney stones. And screening involves blood tests, urine tests, and also the 24-hour urine for confirmation test and all, ultrasound Doppler, only in specific people as they are required. Golden rules for general public is to keep fit. There's for the primary prevention, healthy, to keep the BMI down, control the blood sugar, control the blood pressure, don't smoke. Important is to take hydrate. There's one study which was done recently showed that all Indians are low in their water intake. So we have to keep up with the hydration.
Put 3 liters should do?
Minimum. So secondary prevention, that means once you have a blood pressure, keep the blood pressure at targets, use the medications that will reduce the protein leakage, safer medications, diet changes, control the glucose, lipids and anemia better, smoking cessation and physical activity to be maintained. Mainly to check on with the doctor. Summary: kidney is common, disease is common, harmful and treatable. Early detection will definitely prolong the kidney function and delay the onset of dialysis. It increases the heart disease. Kidney disease increases the heart disease, therefore the financial burden can be taken care of. And mainly for us doctors. I think this is the only slide that I want to reiterate. For common people, whatever we tell, we tell. But it is the onus is on us that kidney disease is silent, blood pressure is, hypertension is silent, diabetes is silent. Unless we look, we won't find. So we have to be more proactive in identifying it and then educating the patient and then ensuring that they are protected. So look at the GFR and not the creatinine. I definitely encourage everyone to do the vaccinations. We really cannot afford kidney disease because I think this is the only disease that actually makes rich poor very fast.
What vaccination are you talking about?
All the vaccinations,
adult
adult vaccinations, usually flu vaccine, very good. Flu vaccine, hepatitis B vaccine, pneumonia vaccine, all these are recommended in our general public as well.
But how is it going to help for kidney?
Okay, first and foremost, as any kidney patient, if they first of all, their ability to fight back an infection is much lower. And as such is an elderly whose immunity is also low, they cannot fight back, so they are easy to get the infection. And once the infection comes, it goes into the organ problem as well, like pneumonia and other things, which will make the patient sicker. Basically, the infection is going to the kidneys as well. Kidneys also get affected as a part and parcel. Kidney also plays a major role as a defense mechanism, so it is definitely affected. And if you might be knowing any sepsis, first thing that shuts down is the kidney. So then that's one, you can protect the kidney. Not only that, the medicines that we'll be using for the infection will also be affecting the kidney. So it's a triple layer. It's not directly, but indirectly, it definitely helps and recommended to take the vaccinations. So Together we can lower the burden of the nation. Thank you so much.
We find the SGLT inhibitor has been used of late very often by the general practitioners, especially in diabetic patients. Now they're going for first line of treatment.
Yes, sir.
What do you experience here?
Being a kidney doctor, I also am very pro for that, especially kidney patients whom we don't have a reason, or in patients who are having a protein leakage or creatinine is increasing, we are using the SGLT inhibitors because they seem to be protected. Number one. However, the main thing is, the problem that I see with that is hydration. SGLT2 inhibitors are very safe as long as the hydration is maintained. If they do that, then there's no problem. And infections, so that they can take care, not many.
If they have some sort of kidney problem, they will involve it. You advise
Yes, sir. There is a DAPA-CKD trial and all that have come up, EMPA-REG trials and all, which are suggesting that any person who has a kidney problem, SGLT2s have a kidney protective effect. So we are using it.
Irrespective of the EGFR, we can give SGLT.
Yes, sir. DAPA we are giving at much lower, up to 30 also we are giving. Up to 30. DAPA we are giving. And EMPA little higher, sir. Not that low. DAPA is the only one we are using till stage 4.
They have come down to 21.
We keep on monitoring. There is no absolute 20-30 difference is not really answer, but don't start it at 20. We definitely don't start at 20. But if we see the benefit, we continue.
Any other questions?
Regarding CKD and the diet, particularly protein diet.
So that is one more thing. Indian diet doesn't seem to be having too much of a protein, so it is really not right to restrict the protein in our Indian population. We are not like Westerners, we don't take that much. So minimum is, even if you want to restrict, first of all, how many of them are even meeting 0.8 milligram per kilogram protein? No, you look at the diet that we are using and seeing, we don't have that much. Therefore, should not restrict. But even if you are restricting, definitely not below 0.8.
We differentiate animal protein and vegetable protein.
Animal protein and this thing. To be honest, in India everybody says don't use animal protein, don't use animal protein. I will tell you, if that is the case, half the world will come to standstill. Okay? That's not what it is. I mean, you need protein. That's period. It's not like you're eating that much of an animal protein and that. Basically, why are we worried about animal protein is because it gives you a little bit more acidosis. But if you can compensate that and then give it, I don't find any problem with that. I encourage, but yes, many of my Indian counterparts, including Anita, may not be agreeing with the animal protein, but I do. I say you eat what you want, but this is the way you need to eat. You need to not overeat your protein, but don't undereat, because today's day, how many of us are telling even our diabetic patients, you're not taking enough protein, please take, isn't it? So if you're restricting what they like, what is the point? So I think judicious.
The significance of microalbumin in kidney disease.
Microalbuminuria is an early warning sign through the kidney, asking the physician to check it out and the patient to be careful about. So, the minute you have a protein leakage, basically what is that telling you is the lining of the blood vessels is getting damaged. And because it is the glomerulus that is going through the kidney and the leakage is happening through the kidney, telling you the damage is happening throughout the body. So, whatever is causing that, take care of that. If it's a hypertension, get that under control. If it's a diabetes, keep that in control. If it's a dyslipidemia, keep that in control. Hydration is important, take it. Do not take any medicine that are toxic to the endometrium. So, kidneys is not direct. It's always looking at everything, all around. So, that's where it becomes a little complicated. Irrespective of what the reason for the protein leakage, as long as we are able to control the protein leakage, there is a benefit. And that is where the studies on the ACE inhibitors, ARBs, SGLT2 inhibitors now and GLPs are coming up, and they're standing up only because, irrespective of the cost, reduce the protein leakage, kidney survives longer.
Madam, I have a patient
Yes, sir.
who has a minimal microbial
Sir.
his urine when he passes it is very frothy and it smells very bad.
Sir. Smelling, I think, has nothing to do with the amount of protein, sir. The froth is
Urine
basically.
culture intensity is normal.
Okay, sir. Basically, no
pH
infection.
is 5.
Sorry, sir?
pH is 5. Urine pH 5.
Acidic urine. Okay. I don't think even acidic urine also gives you the smell. Basically, the froth is equal to the protein.
But
So,
less than 10 microgram.
sir, what is a dipstick?
I agree.
Because many times I'm not very familiar, every lab is very good in detecting it. If a patient is having froth, patient is having protein leakage. If you're not detecting it at that point of time, then just do a 24-hour urine.
No microalbuminuria. Microalbumin less than 10.
24-hour urine paniyacha, sir. For confirmation, always confirmatory is 24-hour urine, sir. That will give you an absolute risk. If there is a protein leakage, froth is there, protein leakage is
No other causes for froth.
not, unless I am using soap or something, sir, not to my knowledge. Protein, froth.
You want to see now? Next slide.
You can even put it on this.
Thank you so much.
Use this for changing these slides.
Yeah.
Thanks, ma'am. In fact, I was just thinking kidney means just urea creatinine, be done with it. It isn't that easy. It looks like just not urea creatinine. If you have bone disease, kidney problem.
Yes.
If you have diabetes, kidney problem. If you have hypertension, kidney problem. Anything seems to be affected kidney. So now I feel kidney is more important than heart. So it's more important than heart.
And the most intelligent organ also, sir.
Kidney is it?
Brain. Yes, sir.
Electrolytes, everything. It looks like kidney is doing a lot of work in us continuously. Kidney seems to be a miracle organ. I think you should take care of it. I just want to ask, is there any food that can harm the kidney? Apart from salt?
Food does.
Any food that can harm the kidney? Like paneer butter masala, can it harm? Because I'm very scared now. See, that thing you say elderly, you got 60 plus everybody.
Sir, synthetic food avoid பண்ணுங்க. Synthetic food
Synthetic
avoid பண்ணுங்க.
Pizza,
fast food, what it contains without knowing you should not take.
Stored food.
It's not good
Stored
for
food,
food.
synthetic food. I mean stored across the counter. அந்த மாதிரி food எல்லாம் வேண்டாம்.
So anything which contains coloring agent, anything which contains preservatives, or maybe all those things have to be avoided, isn't it?
In general, what is bad for the body is bad for the kidney. Kidney doesn't say complain as much.
Very good. Today that's good news. I was really scared now. I was thinking so many food I'm taking, anything is good. Thanks a lot, man. I think that was wonderful. And